Hello, everybody, and welcome. Thank you for joining us for today's call. This is the End-Stage Renal Disease Network Learning in Action Network Series, Bloodstream Infection Quality Improvement Activity. This is Stephanie Hull, and I'll be your host for today. I want to just go over a few reminders before we get into the presentation. We are streaming the audio over the computer speakers to free up phone lines in your facility. If you need to dial in from your phone, send us a message via the chat window and we can assist you. If you're hearing echoes are caused from multiple connections to a single event, so please close all but one of your browsers. And we do want to hear from you, so please submit your questions and or comments to the Chat with Presenters section located in the bottom left corner of your screen. Also, this event is being recorded and all the material will be available from your network representative within 10 business days. This event is approved for 1 CEU. At the end of the presentation, please do not shut down your computer or sign off. A post-event will appear, and that's going to give you the opportunity to share your feedback. And then after submitting the feedback form, a pop-up screen will come in and it will appear with the links to the CEU. So why are we here today? It's the reason for participating in today's LAN. It's going to be able to learn to develop a team approach that embraces culture change to decrease the bloodstream infections in your facility. And ways to spread the best practices from today's LAN. We want you to listen and share your approaches and experiences via the chat. We'd like you to identify how this shared information could be used at your facility and apply at least one idea from today's LAN at your facility, something that you can go back and implement that will help improve the reduction of BSIs. And what can we commit to do today? I think after the presentation and during the presentation, you're going to hear a lot of good best practices, a lot of shared ideas, and what's worked in their facility. So we're asking you to commit to identify and implement one action item from today's meeting that can directly decrease the number of BSIs in your facility. Before we get into the presentation, I do want to share with you the results of the pre-work questions. We had several people take them. We had 366 to be exact. The first question was, does the facility where you work have daily huddles to discuss BSI and ideas that impact infection prevention? It was kind of a split decision. 52% said yes, they do have daily huddles and discuss ideas, and 48% said no, they do not. The second question, do you believe that audits of staff technique are valuable or used for discipline? So again, out of the 366, 347 or 94% said yes, they think they are valuable, and only 19 or 5% said they use it for discipline. So our speaker today is Ashley Rotella. She is a nurse manager at University Massachusetts Memorial Medical Center in Central Massachusetts, where she oversees the inpatient and the outpatient dialysis services. Ms. Rotella obtained her Bachelor of Science degree in nursing in 2007 and her Master of Science degree in nursing at Walden University in 2017. She is currently enrolled in the Doctorate of Nursing Practice at University of Massachusetts Medical School. Over the last 2 years, UMMC has served as a host to the Department of Public Health and their infection prevention program. The dialysis facility has completed 2 deficiency-free surveys and has had 0 access bloodstream infections for nearly 2 years. Ms. Rotella is passionate about self-development to improve skills to lead and develop individuals and teams. She is also dedicated to the specialty of dialysis and strives to improve the care delivered to dialysis patients within the community. I'm going to now turn this presentation over to Ashley.
Thank you, Stephanie. So good afternoon, everyone. Thank you for joining today. Let me start by giving a little introduction of myself. Again, I am a nurse manager at UMass Memorial Medical Center, and we are located in central Massachusetts. UMass Memorial Medical Center is a 400-bed level 1 trauma center that has an independent dialysis facility with 13 individual stations. The dialysis facility cares for inpatients and outpatients, as well as high-risk populations due to comorbidities and pediatrics as well. I've been in dialysis for over a decade in various roles, including staff nurse, educator, and manager. I currently manage inpatient and outpatient dialysis services, as well as the IV resource department. Next slide. I have no conflicts of interest in regards to this presentation today. Next slide. So the goals of this presentation are to outline bloodstream infection trends at UMass over the last 5 years, to explain the transition of the bloodstream infection tools utilized over the last several years, and lastly to describe the current state of bloodstream infection prevention at UMass. Next slide. As you can see, the incidence of access-related bloodstream infections has steadily decreased since 2014. In 2014, the UMass Dialysis Department received condition-level citations from the Massachusetts Department of Public Health during a relicensure survey. Surveyors found significant deficiencies related to infection control practices, failure to ensure staff adhered to minimum infection control practices when accessing and deaccessing a central venous catheter or an AV fistula was cited, in addition to many other citations. In response to these findings, the facility leadership during this time implemented auditing as a significant component of the corrective action plan. Next slide. Prior to the survey completed by DPH in 2014, the staff had not been exposed to auditing or practice review with any regularity. Therefore, as you can imagine, when the auditing began abruptly after the survey, it felt unfamiliar, demeaning, and punitive. During these audits, there was no opportunity for conversation or collaboration in regards to practice, and auditing quickly took on a negative connotation. The staff began to refer to auditing as clipboarding when leaders walked around with a clipboard reviewing the care that the clinical staff rendered to patients. This elicited fear and discomfort. Of consequence, the staff felt the lack of dialysis experience by leadership during this time was a disservice to the department. The quality of the audits in relation to the knowledge by those auditing was minimal. In my opinion, auditing is a tool to be used in conjunction with education and support, and I don't think that audits should be used as part of the discipline process. Next slide. In 2015, there were changes to leadership within the department. I was hired into the dual role as a nurse manager and nurse educator for dialysis services. Although I had been a per diem nurse within the department and felt I understood the concerns, it took time to fully appreciate where the staff were, how they felt, and what they needed. Of course, the culture did not change immediately. There was a lot of feelings of distrust and fear, and that were very prevalent. It took time to build the team back up, and eventually staff either jumped on the train or moved on to other roles within the organization. While the idea of a dual role can be overwhelming, and believe me, it was to me, I believe there are many positive attributes. A dual role allows the person managing to fully understand the needs and opportunities within the department. It minimizes any disconnect and creates comfort between the person in the role with the team. At UMass, there is a nursing professional development department that does an amazing job supporting me in the dialysis department, especially with items not directly related to my specialty of dialysis, such as basic life support, restraints, QIAC, and telemetry. Next slide. Core interventions. Since 2016, several interventions have been implemented and have been instrumental in maintaining a culture of safety as well as zero access-related bloodstream infections. These interventions include a unit-based council as part of shared governance, daily huddle, utilization of the Days Without a Bloodstream Infection poster, intermittent auditing, and annual simulation. And these core interventions were not all adopted at the same time. These core interventions were adopted over a period of the last 3 to 4 years. Next slide. So unit-based council Implementation of a unit-based council is important to build consensus and buy-in. Unit-based council is a part of the shared governance model and a model used in healthcare to integrate core values and beliefs that interprofessional practice embraces as a means to achieve quality care. This model was created to improve the nurse's work environment, the nurse's satisfaction, and nurse retention. It also promotes engagement and ownership of changes in the workplace. And we all know that change is difficult. A recent study supports the shared governance model and the relationship between increased employee satisfaction with increased job satisfaction, leading to higher retention. Our council includes the dialysis nurse manager and the director of critical care services as co-chairs, in addition to 3 or 4 clinical staff members. The council meets monthly to discuss various items, including but not limited to evidence-based practice, departmental policy and procedure, which require review a minimum of every 3 years, concerns within the department, and educational opportunities. The clinical staff members are essentially liaisons between the team and the daily work to leadership. Our policies and procedures are based on the most recent ANA core curriculum as well as CDC recommendations. However, policies and procedures are not implemented without input from clinical staff members and are only adopted into practice after consensus is reached. Having worked in various organizations, I have found that involving staff in the direction of their work by including them in policy and procedure creation leads to increased levels of compliance. I understand that some of you may work in organizations where you do not have the ability to be part of the policy and procedure creation process. If so, then create a unit-based council that is based on process improvement in your facility, and I'm positive that this council will empower the employees to bring forward areas of opportunity that lead to a lack of compliance. And as a team, you can storm and norm. So talking stages of group development are form, storm, norm, and perform. This model of group development is great to review for guidance prior to the first meeting. Pictured on this slide is the meeting agenda and minutes from a previous meeting that we've had in our organization. Next slide. Next, we implemented Daily Huddle. Monday through Friday at 10:30 a.m., a time that the staff selected, daily huddles are held by the nurse manager with the expectation that all of the staff that are working attend unless patient care needs arise, which would take precedence. I have found staff are eager to attend the meeting and schedule their day around our huddle. Huddle generally lasts 15 to 20 minutes and does not take the place of staff meetings, although we do have staff meetings less frequently now. The minutes from our daily huddle are emailed to each staff member daily so that everyone can review items discussed. If staff do not have an email, then a binder might be another great way to communicate day-to-day minutes. The huddle agenda starts with our organization's goals and then goes through recognition of each other, staffing and patient assignments, new ideas and ideas in progress, bloodstream infections and days without a BSI, and lastly, general discussion. I find each of these topics are important in order to fully support the staff by listening to their concerns. It allows the staff an opportunity every shift to discuss work-related concerns or issues instead of feeling that they have to seek me out. Also, we are an ideas-based organization, meaning we believe that ideas of the staff closest to the issue have the biggest impact. In 2019, we have implemented over 30 employee ideas in the dialysis department, including ideas that directly impact the prevention of bloodstream infections. New ideas, old ideas, or ideas in progress are discussed, and everyone has an opportunity to hear the idea and give feedback prior to implementation. This process of idea sharing definitely takes good ideas and makes them great. Some great ideas from this past year include use of a skin prep to use on patients when the CVC dressing does not adhere to the skin, changing the acid clean process to disposable jugs instead of reusable, print and laminate communication cards for non-English speaking patients, a hydration station for staff, ordering wool hats to give to patients when they are cold, and those are just a few. So as you can see, the ideas range from patient comfort, bloodstream infections, process improvement, they're kind of all over. One of the most simple yet impactful ideas that came from Huddle this year was creation of a pyrogenic reaction kit with diagrams. While debriefing after a suspected pyrogenic reaction, the staff discussed how difficult it was to gather all of the supplies and respond to a suspected pyrogenic reaction. So we created a kit with all of the supplies, a copy of the procedure, and a diagram in regards to water samples and where they should be collected. Over the years, huddle discussion regarding bloodstream infection prevention has evolved. Staff are now eager to discuss patients with risk factors, and I think this truly prevents infections. In regards to central venous catheters, staff discuss a wide range of concerns, including patient education, skin irritation, patient complaints, and much more. These conversations highlight the at-risk patients, and from there we decide where the information needs to go, such as to the provider or to another specialist, so we can discuss necessary changes to the patient's plan of care. Sometimes patients need additional education. Other times they need an alternate dressing, such as a sorb review versus a Tegaderm. We have piloted and adopted products such as StatSeal to help prevent bleeding from an exit site immediately post-placement. Huddle has given the team a place to bring these concerns and questions forward in a comfortable and a relaxed environment. It's also an opportunity for education and updates. Next slide.
I think we're going to do our first polling question here. Yes. So does your facility encourage staff to make suggestions for solving issues? So we'll give everybody a few seconds to have an opportunity to answer that. And they're coming in quite rapidly, so we'll just give them a little bit of time. All right. Yeah, we have over 400 participants, so I'll close the poll here in 3, 2, and 1. Wow. So that was, does your facility encourage staff to make suggestions for solving issues? I'd say overwhelmingly, almost 97% answered that yes, and only 1.4 or 6 respondents said no. So, all right, Ashley, I'll turn that back over to you.
Okay, so as a hospital-based facility, we see a high percentage of catheter patients. So I'm not looking to endorse any product in particular. However, I would like to present a few key findings that we have learned over the last several years. So catheter patients are not a one-size-fits-all in regards to maintenance and care of their line. Our standard procedure here is chlorhexidine scrub with a 3M CHG impregnated dressing, which is pictured on the bottom right of the slide. The picture on the top left of the slide is an alternate dressing we utilize for patients that have a Tegaderm sensitivity. And usually with this sensitivity, you're going to see itching that is unrelated to the CHG. This dressing is called a sorb review dressing and is used with a biopatch to maintain the exit site. Another product that has been piloted in our facility is StatSeal. This product is used to decrease or stop oozing from the exit site, often used immediately following catheter placement due to a fresh surgical site. So the data suggests that 67% of dressing changes are unplanned, which puts our patients at an increased risk for infection every time we do an unplanned dressing change. So the goal is to prevent unplanned dressing changes by using the right product. Additionally, over the last 5 years, we have implemented changes that had a direct cost savings and did not negatively impact excess bloodstream infections. So an example includes transitioning from 4% sodium citrate locks to Tegos connectors with alcohol impregnated Kuros caps. Next slide. Again, patients are not a one-size-fits-all when it comes to care. Every organization should have a primary and secondary procedure for care and maintenance of a CVC. A standard dressing with standard care will not work for all patients. Therefore, alternate procedures and supplies for allergies, skin breakdown, and sensitivities are important. Staff must be educated and comfortable with all of the procedures and policies associated with the care and maintenance of a central venous catheter in order to provide the appropriate care to each patient. This slide outlines our facility's secondary procedure for patients with a chlorhexidine allergy and is broken down based on non-intact versus intact skin. Next slide. The Days Without a Bloodstream Infection poster is a great tool that was created by the Center for Disease Control and Prevention, and this poster is hung in the center of our nurses station, and it's updated daily during our huddle. It's apparent the staff have developed a sense of ownership in regards to the number on this poster, since they will always ask questions if a day goes by and it doesn't get updated. They ask for the new number. use an app on my phone. I use an app on my phone to track the number of days since the last access-related bloodstream infection to keep us honest. Some departments in the hospital have a digital tracker, which is a great way to track the days as well. Next slide. So clinical audits are completed and reviewed monthly at the department quality meetings. Any score less than 100% requires remediation between myself and the staff member. Remediation is generally a discussion of the practice that needs improvement. Auditing provides a great baseline for educational needs within the department and is used as a tool for the manager and the infection control specialist to highlight areas of opportunity. Auditing is not used for discipline in our organization. Slide is an example of an audit tool that was adapted from the CDC tools. Personally, we found that the more specific the auditing tool was in regards to our organizational policy and procedure, the more meaningful the conversation we were able to have with the staff member at the time of the audit. Next slide. The last core intervention is annual simulation, which I love. Staff are required to attend simulation every year. Simulation is an interactive session with a dummy chest and a dummy arm, and the staff access and deaccess the catheter as well as the AV fistula. Policy, procedure, and process are reviewed, as well as hot topics such as tape, gauze, needle safety, safe reinfusion, and much more. The environment stimulates a lot of great discussion among the attendees in addition to open conversation and questions. It's funny that the staff, when they're in a group together doing simulation, feel at ease to say, well, that's not necessarily how I do it. So it really brings out the honest truth about the practice that's going on in the facility, and it's a great opportunity for education. We use the dummy arm and the chest pictured as well as a primed HD machine, so the setup of the bay is as genuine as possible. Also, we intermittently use artificial blood and perform random blood spill simulation throughout the clinic to make sure everybody feels comfortable with blood spills. Ensure that high-risk and low-volume procedures are reviewed often enough for employees to remember how to react. So blood spill is one of those high-risk, low-volume incidences that can happen, and if we don't practice, we don't feel comfortable. Next slide. I'd be remiss if I did not include the patient and the education they receive in regards to their access. This handout was created for our dialysis patients that have a central venous catheter, as they are at an increased risk of infection. Every patient is educated on the care of their access on admission and as needed. This handout clearly shows the patient the part or products that make up their central venous catheter, as well as where the tip terminates in their body. And I don't think without that picture they truly understand the catheter is in their heart, and really the magnitude of the catheter. Next slide. So many misconceptions have been dispelled over the last 5 years at our facility. First, utilizing the CDC tools is extremely important, but each facility should use the tools in a way that is meaningful for them. For instance, we've added to the audit tools so they reflect our practice and policy within our organization. Therefore, any conversation about policy can be quickly resolved and no follow-up is required. The Days Without a BSI poster is a great tool and should be utilized in daily discussions. I think without frequent discussions, it becomes another piece of wall art. Engage with the staff in infection prevention. Daily huddle and unit-based counsel work well for us, but find what works best for your department. Annual simulation and auditing are not the same. Annual simulation in a test environment is a great opportunity for staff. If scheduled in groups, it creates an opportunity for staff to learn and support one another. For us, annual simulation has evolved over the last 4 years. Prior to this past year, each staff member used to complete annual simulation separately, and I found over time that that was a little bit more intimidating for them than doing it in groups, so groups seem to work well for us. Make every effort to schedule annual simulation outside of patient care hours so that staff don't feel pressured to get back to the bedside or the chair side. Work to create a positive learning environment. In order for infection prevention to be successful, staff have to be involved in the discussion process and outcomes. So that's great that the poll showed 98% of staff are able to come forward with their thoughts and ideas. With every infection, staff should be at the table to discuss the root cause analysis. And the root cause analysis should be held for every infection, frankly. If there's an infection, we should sit down at a table and we should discuss the infection. RCAs should not be intimidating. They should be viewed as a work group to define the problem, collect data, identify potential causes, and identify solutions. Ultimately, solutions should be monitored for outcomes in order to PDSA, plan, do, study, and act. In 2017, a patient had an access-related bloodstream infection in our organization, in our department, that should not have occurred. And through discussion of practice and review of the data, the microbiology data, it was clear that the infection was related to a practice that was preventable on our part. This infection was a pivotal moment in our department. Once the staff realized it was a practice-related infection, I think they realized just how important their work is to our patients and the patient's outcomes. Too often RCAs don't include the staff, and the discussion does not reach the staff in a meaningful way. I want to give a huge thanks to our nurses, the PCAs, my director, and our infection control specialist who support the work that we do. The triumphs we have experienced here at UMass are a result of all of these team members. Lastly, I would consider reading Why Hospitals Fly, Even If You Work in a Clinic by John Nance. It's a great read on patient quality and patient safety. Next slide.
I think we have a polling question. Yes, so we do. So the second polling question, which lessons learned could your facility benefit from using? So I open up the polling question. We'll give our participants a little bit of time to respond. And I will close that out in 3, 2, and 1. All right, which lessons learned could your facility benefit from using? Almost 11% said the CDC tools to mirror the P&Ps. Discuss the days since last BSI, about 20%. 43.7% engaged staff in reducing infection, and 25.7% said utilizing annual simulation. And somebody came through the chat, thank you, Stephanie, said she'd do all of them. We didn't put that down, never thought about that. So good point. Those are all good suggestions and good lessons. So Ashley, anything else before we go into questions and answers for you?
No, just thank you all for taking the time out of your day. I know how busy all of you are. I hope that you had one takeaway from this discussion that you feel would be useful in your organization, and I'd be happy to answer any questions that you may have.
And we do have some questions coming in, and please, to the participants, continue to submit them through the chat. We're going to go ahead and start with our questions. The first one is somebody was asking, Ashley, what's the name of the app you used to track your infections?
Oh, yes. Let me, so it's just a basic app that's going to allow you to put a date in and track it. So it's called Days Since, so DAYSSINCE. And it's just an app that allows you to track since the last infection. And it's free, which is even better.
Good. Amy asked, what was the name of that book again, the one I think you just mentioned at the end to read?
Yeah, so it's called Why Hospitals Should Fly by John Nance.
Good, thank you. And let's see, we have, Sandra asked, where do we find the days since last BSI poster?
The CDC website has all of the tools available, and you can print it and laminate it is the best way to get it up as soon as possible. And I'm sure you can order them too. I think our networks also have them available, but I don't want to commit to that answer. But I know they're on the CDC website.
Great. Thank you. Let's see, Barbara asks, can we have permission to use the patient training or at least the photo of the CVC?
Oh, yeah, absolutely. I would just change, like, our clinic phone number is on it, so I could send that to Stephanie and she can send it out.
Yep. Yeah, if you can send me a copy that doesn't have your phone number, I'd be glad to include it with all the other material when we send that out. Okay.
Sure.
Thank you. Okay, let's see. Question for you, Ashley. What do you think of gauze dressings for CVC dressing? I questioned that in our facility, and they said it's due to the importance of having a non-occlusive dressing.
Well, I think it's a great question. For us, in my practice, and this is all hypothetical, I have seen better outcomes with an antimicrobial occlusive dressing. I've worked in settings where we've used the gauze, and gauze is great if you have oozing because it absorbs it. You don't want to use an occlusive dressing if you have oozing. But once that site is healed, I found that occlusive antimicrobial dressings really help prevent infection. But that's hypothetical, not based on research. I'd really have to go look at the research to see if there's any hard evidence proving that.
Okay. Robin asks, can I put the slide back up with the step-by-step checklist for the CBCs? But that's...
Oh, the audit tool. Yep.
There it is. So I think, Robin, that is the one. I'll leave that up for a little bit then for everybody to look at. Ashley, can you speak to where you got that at?
Yeah, so again, this is an audit tool taken from the CDC website. And what we did was the CDC tools are going to give you the minimum requirement, right, for care. And so we love here to go above and beyond. And so scrubbing the hub, we scrub the hub in between every time something is attached or detached from the lumen. I don't think that happens throughout the entire community or country. Usually I hear a lot of people scrubbing the hub only once with access or deaccess. So as you can see, you're going to see a lot of scrubbing the hub. That's what we do, a lot of. And we also do treat it as an aseptic technique. Not sterile. We use sterile gloves and we use a sterile field, but it's aseptic, as clean as possible, but it's not a sterile procedure.
Great, thank you. Let's see. I have a question. What are the specific topics for your huddles?
So the specific topics, I have our huddle today right in front of me. So I start with our values of our organization because it's always good to be reminded of how we should be practicing every day. And then I start with hot topics. So right now a hot topic in our organization is the wet time. So the bleach product that you use, what's the wet time and what is wet time? Then we go through recognition. So it gives the staff a chance to say, you know what, Sally, thank you so much for helping me today. I couldn't have done it without your help. So it's a really great way to start off positive with recognition of each other as a team. And then we talk about staffing and patient assignments. So we talk about the staff on, how the assignments are going, if there's any barriers to patient assignments, if there's anything we need to discuss. Then we talk about, we implemented Epic about 2 years ago now, so we talk about any issues with the electronic medical record. We talk about employee ideas, so we have an idea box and we'll take out the ideas and we'll discuss them. And if there's unfinished ideas from the previous days that are still out there to discuss, we continue to discuss them. So we tend to discuss an idea for a week so that everybody on the team has a chance to hear the idea and have input on the idea. We talk about days without a bloodstream infection, and then we talk about any patients that are at high risk that we would consider at high risk or any concerns of patients who are at risk for a bloodstream infection. And then we leave time for general discussion so that staff can bring up anything that they feel that they need to talk about.
Great, thank you. Well, let's see, we've got a question. Does the CDC have an app to track hand hygiene observations?
They have an audit tool. I don't know if the CDC has an app. That's a great question. I'll have to look at that. But they do have an audit tool to track hand hygiene.
Good, thank you. Miriam, just a comment. She says you can order the how many days since last BSI poster from the CDC. So just for the couple that asked about that, it is available. And Ashley, how did your facility initially respond to having to attend the daily huddles? What ways did you encourage them to attend?
So initially, I think they found it difficult to, because the staff are so busy and they're, working with patients, and it's hard for them to take their break, never mind come to a huddle. But once we started, I explained to them why we were doing it, because a lot of times your staff are trying to seek you out in between meetings and in between the things that you have to do, and it's a great time for all of us to get together. So once I understood the concept, that it was really to help support them. It wasn't about me trying to say, here's a new procedure, look it over, you got to do this. It was really more based on, this is your time to be able to talk about for 15 or 20 minutes things that we need to or I need to address. I find a lot of times I'm walking away from huddle with a little bit more work to do, and that's okay. But once they understood it was for them and to support them and to support their work, and they really committed to that 10:30 a.m. time, and I let them pick the time so that it was convenient for them. They are there now. I'll go out and go to the nurse's station, and they're standing there waiting for me. So they really, it only took like a month or two, and they were committed to doing it. And if we don't do it, if there's a day that for any reason, if I take a vacation day, they tend to do it on their own now and then leave me the minutes.
Very nice. Just a quick question again, Ashley. Can you repeat the name of the app to track the infections?
Yep, it's called Days Since.
Great. So Joe asked, what's the reason behind the sterile versus your clean gloves for your dressing changes?
That was a decision made at the organization level in 2014. Honestly, before I came into the role as the nurse manager educator, but it was a decision that they had made to really focus on infection prevention. And I think that we all see the hands that go into the box of gloves, and the box of gloves don't get replaced until they're empty, and they sit out and they're open. And we just really wanted to focus on any avenue that we as caregivers can contaminate the access.
Good. Joy asks, would you use the poster for any BSI or specifically for your access-related infections?
We use it for vascular access-related infections. You could have two. I know they just updated it recently to include catheter days.
Okay. Here's a comment from Yolanda. She said, we also scrub the hub between every connection and have had success with the HCG impregnated disc with transparent dressing changed every 7 days. So much like what you are practicing, I believe.
That's great. And that also answers the person's question about gauze dressing. Kind of supports that work.
Great. Let's see. We got to go on to a few more questions here. What was the dressing that you used for patients with a CHG sensitivity?
So with the CHG sensitivity, this is a good question. So if they have a tegaderm sensitivity, we'll use the Sorb review with a biopatch. Now, if they have a CHG sensitivity, you can't use biopatch because biopatch has CHG in it. So with a CHG sensitivity, we cleanse with iodine, with 3 different swabs of iodine, and we use a basic tegaderm, not impregnated with antimicrobial.
Okay. Thank you.
You're welcome.
How long are your huddles on the average?
On the average, usually 20 minutes.
And then what is the difference between then a huddle and a staff meeting?
So huddle, we have general topics, and we kind of let the staff kind of, guide the conversation, and it's really based on that day. So like we're talking about staffing and patient assignments, we're talking about barriers to that day or things about that day. So it's really focused. Where a staff meeting is long-term goals. When we were rolling out the new EMR, having staff meetings about the EMR, the plan. So it's really more long-term, what's happening long-term.
Okay, another question here from Allison. Are techs or nurses doing your CVC care?
Nursing.
Okay. There's a question here. Says, can you share what deficiencies your facility received, 4 years ago?
So it was before my time. It was in 2014, and they were primarily infection control based, and it was a 100-page report. So honestly, it was use of PPE, so donning and doffing. It was, like I said, accessing and deaccessing. It was making sure how you treat the machine after patients, how you clean the machine, where you store products, how close are they to the bay, what goes in the bay, what goes out of the bay, tape, how long do you let it sit with your strips with, we ended up, there was a lot of multi-use items that didn't, it could be a risk of infection, could be a risk of cross-contamination. So those were a lot of the things that, it was a lot of infection control things.
Okay. Thank you. Let's see. We have a kind of a request. It asks, please further explain the 3 separate betadine swabs for patients with CHG sensitivities during dressing changes. Do you allow to dry per manufacturer's recommendation after each swab?
So the 3 separate iodine swabs, we do not let it dry after each swab. So we don't use a iodine prep pad. We use swabs because we believe that you use the CHG swab or the iodine swab, you're not making contact with the exit site with your hands. So we clean with the iodine, 3 separate swabs, and then we let it dry before we place the dressing.
Okay. Another question from Bradford. Any concerns with using a skin prep to reduce skin irritation when utilizing antimicrobial occlusive dressings for CVCs?
No, there's been no concerns. We've worked closely with infection control to make sure that there would be no concerns, and it's a sterile product.
Okay. How do you ensure staff is following protocols when supervising staff not present?
I guess I don't understand the question. So I audit them and spend a good amount of time out on the floor to make sure that I'm kind of just watching their, how they're caring for the patient.
She might be asking if you're not there.
Oh, if I'm not here. Well, I feel like I'm here a lot. So I'm not sure. I guess that, simulation is a good place to really go back and talk about practice. We have to audit so many times per month, so I try to vary how often I'm auditing and who I'm auditing. And I do see all shifts.
Okay. Here I've got a kind of a question and a comment. Mary Lou asks, where can I get a copy of the Care of Your Hemodialysis Catheter? She says it's a great education tool for our patients.
Oh, and that's the one I was going to send to you.
Perfect. Okay.
So I'll send that out to you.
Well, I think this is the same question. Where can we find the picture where it says Care of Your Hemodialysis Catheter with the picture of the catheter inside the body?
So that I got, no, that I just got from a Google search. Just finding a picture that really outlines the product, the CVC. And then I added the labeling.
Okay. Good, thank you.
You're welcome.
Question about the days since last bloodstream infection poster. Is it to be only for the CVC AVF that's caused infection, or is it any bloodstream infection?
So I think you need to make the decision about that, whether you're going to do any infection or you're going to do days or use it for your vascular access related infections. You could certainly use two separate ones, one for non-access related infections, one for access related infections. We use ours for vascular access related infections.
Good, thank you. Question here, do you allow the techs to do VASCAF care?
We do not.
And here, this is kind of a comment from Michelle. She says, we've ordered a heart model and drilled a hole in it, inserted a catheter for hands-on.
That's a great idea. That's a wonderful idea.
Wendy, I don't think you did say, Ashley, but she wanted to know what Google site did you find the CVC inside the body on?
Oh, I don't remember. We made that a while ago, but I can certainly email to Stephanie.
Okay, that would be great, and I could share that out with everybody.
Mm-hmm.
One more question here. It says, asks, can we train technicians to perform VASCAF care?
So I guess, so that ranges state from state. Like I know New York does not allow technicians to do catheters. So you really have to look at your state laws and then your organization policy. So that's really where you need to start. But anybody can be trained to do anything, hypothetically. You just have to know what your laws are and what your policies are in your organization.
Okay, I think you're correct on that. It is a state-by-state law.
Yeah.
I have kind of a request about your huddles, your little topics, and can she give us a list of topics in the huddle to sound out with the presentation?
Yeah, absolutely.
Does that form you use, is that something you have made up also for your huddles?
So one of the forms was our agenda and minutes from our unit-based council. But my huddle, I just use a Microsoft Word document that's pretty blank and just has the topics listed. So that way I have room to write down what we talk about. So, but I can definitely send out a list of topics.
Okay. Great. Well, we had quite a few questions today, and tonight we've actually got through those we've got through all of them. Is there any other questions from the audience I would like to ask Ashley? I know we covered a lot of information. There's a lot of good best practices. I'll be sending out all these materials again to within 10 business days to your networks, and they will be then sending them out to you. So is there anything else, probably before we wrap it up? Please send it in through the chat. while we're waiting and closing up, I do want to ask that if you do have any best practices in your facilities, we'd like to hear from you. Much like Ashley, she has volunteered to come in, share her best practices. I think this is some really good interventions today she has shared. And if you have the same you would like to share with us, please let us know. We will be starting on our 2020 QIA lands, and the next one will be January 7th, and we'll be looking for speakers to speak for the next year. You can also follow the NCC on Facebook, Twitter, or YouTube. I do have one last question that came in, and I'm sorry, Lorna, I can't type it in, but it asks, can you type in this window, the name of the app. We could probably, and it's, Ashley, it's, tell me the name of the app.
So it's one word, and it's called Days Since. So DAYSSINCE.
So Days Since.
Yep.
So I can type it into the window, Lorna, and there it is for everybody again, one more time, Days Since, all one word app that you can track your own Days Since less BSI. Well, if there's no other questions, I don't think there's any more in the chat. Again, reminder everybody, please stay on. If you want your CEUs, or even if you don't need CEUs, we would really like your feedback for the survey at the end of this. When I close it out, if you stay on, it will pop up on your computer. Take them a few minutes just to answer it. If you do need CEUs, once you submit the survey, then the links to the CEUs should appear, and then you can access them that way. So again, I want to just thank everybody. I certainly want to thank Ashley for taking time out of her day to do this presentation. A lot of wonderful information today, and thank everybody for attending and taking time out of their busy day to join us. And this will be the last one of this year, of 2019, but we are working on our agenda for 2020 and more to come. So I just want to wish everybody happy holidays, and we will be talking to you soon. And thank you again, everybody, for joining today.
Thank you.